Hello, web shadowers. Thank you all for attending our session this afternoon.
Today, we are honored to re-host Dr. Manjaly, who is a London-based ENT surgeon.
As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end.
So with that being said, Dr. Manjaly, you may begin whenever you're ready.
Great, thank you both. Thank you for having me back. So for those of you that used to log on to Web Shadows early on, I did a talk on ENT emergencies. And it's great to come back and do a talk that's more focused on ear problems, which is what I specialize in. So as Erin and Isa said, I am an ENT surgeon based in London, and I specialize in hearing restoration surgery. And you can find my details on that slide there. So the thing about ENT is you don't get exposed to it very much at medical school. And because of that, a lot of people just don't discover it until very late on. But being able to restore hearing is precious, it's emotional. And as you can see here from YouTube, someone having their cochlear implant switched on and being able to hear for the first time in a long time. It's amazing stuff. So I guess that's the kind of set the tone for the rest of the talk. I'm going to cover lots of different ear conditions that you will come across and need to know about. I hope it's useful, and do ask questions if you need to. So ear problems are really common, and it's very common as in family medicine, in the emergency room, as well as an ENT junior doctor, to see patients with ear problems. Now, even though you get taught how to use an otoscope at medical school, I can be honest enough to say that actually being able to see clearly what you're looking at with an otoscope can be quite difficult. You know, at the very most, you can probably tell normal from abnormal, but sometimes it needs more than that. And so I'm going to start with talking about how to interpret hearing tests, because you can, by understanding how to interpret a hearing test, unlocks the understanding of lots of different types of ear problems. So I'm going to start with a question. It's right here. So here's I don't expect you to know the answer, but just give it a go. I'll keep an eye in the comments. See if you can answer this. There's a slight delay, so I'll give it about a minute and see if you can answer this question. So 24-year-old patient, what is the most accurate interpretation? Is it a left conductive hearing loss, bilateral sensory neural hearing loss, a right mixed hearing loss, bilateral conductive hearing loss, or right-sided conductive hearing loss? Okay, I'll give you a bit more time to post what you think is the answer in the comments, and then we'll move on. Okay, so the correct answer is bilateral sensory neural hearing loss. Okay, you can see, I'm going to explain why, but have a look at the O's, the X's, and the triangles, and notice that they're all on the same line, and there is a drop in the higher frequencies. Okay, so types of hearing loss. Broadly speaking, there are different types of hearing loss dependent on where the problem is. So if you look at this diagram, sound travels into the ear canal, goes down the ear canal and vibrates the eardrum, the tympanic membrane, which in turn is connected to three bones, the ossicles, the malleus, the incus, and the stapes, which together are called the ossicles. And the third hearing bone, the stapes, connects to the oval window of the inner ear, where those vibrations are converted to electrical signals, which are sent down the vestibulocochlear nerve to the brain. So if you have a problem with the ear canal or the middle ear, i.e. the space behind the eardrum, signified by this red section, then you're going to get a conductive hearing loss. If you have a problem with the inner ear or the nerve or the brain, it's going to be a sensory neural hearing loss. And if you have a bit of both, it's going to be called a mixed hearing loss. So how do we interpret an audiogram and map it to this? Well, have a look at this. So this is an audiogram, a blank audiogram. As you can see, On the x-axis, you've got different frequencies, so low pitched notes to very high pitched notes. And then on the y-axis is a logarithmic decibel hearing threshold scale. So you test the quietest sound the patient can hear at different frequencies, and then plot that on the graph. We consider that 20 and above is normal. And here you can see that there are different signs for each type of test. So there are two things that you're testing, right? So bone conduction and air conduction for each ear. Okay, so now why test bone conduction? So bone conduction is tested by vibrating the bone behind the ear, and that sound goes directly to the inner ear without involving the ear canal and the middle ear. So what bone conduction does is it's a surrogate marker of inner ear function. So how well would you hear if your middle ear was working perfectly? Okay. So if your middle ear is working perfectly, then your air conduction, which is your natural hearing, should be the same as your bone conduction. And so if there's a hearing loss in the bone conduction and there's no difference between the air conduction and the bone conduction, then you know that the problem is coming from the inner ear or beyond, and so it's a sensory neural hearing loss. Whereas if there's a gap between the two, what we call an air bone gap, that signifies a problem with the middle ear, which is what you see in conductive hearing loss or mixed hearing loss. I hope that makes sense. So take this audiogram, for example, okay? So X's are left air conduction. And if you look at this curly ear, imagine that you're looking at someone's ear straight on, their left ear. The left bone conduction is better than the left air conduction. So the inner ear is working better than what the natural hearing is suggesting, which means that the problem must be somewhere between outside of the ear and the staypiece. So that's a conductive hearing loss. So by seeing an air bone gap and inferring that there is a conductive hearing loss, you know that there's going to be a problem that you need to find in this area. So that can really help make a diagnosis. And once you've differentiated between conductive and sensory neural hearing loss, then you know the common things that cause each one, and then you can narrow down the diagnosis. Okay, now it's really important to be able to differentiate between conductive and sensory neural hearing loss when someone loses their hearing suddenly, because sudden sensory neural hearing loss is an emergency. We know that if this can happen without any clear cause. If someone complains of sudden hearing loss and it's found to be sensory neural, they need to have early steroids. So either tablet steroids or injected steroids through the eardrum. And if you haven't got access to an audiogram, then you can use tuning fork tests, Rinne and Weber testing that you will have learnt at med school to differentiate whether the loss is conductive or sensory neural. So if a hearing loss is sensory neural, then when you put the tuning fork on the forehead, it should the patient should hear it in the opposite ear. Whereas if they've got a conductive hearing loss, then the tuning fork on the forehead should lateralize to the affected ear. Okay. I hope that's all right so far. Let me know in the comments if I'm going too quickly. So sensory neural hearing loss, sudden, is an emergency. Okay, so let's look through some other ear conditions. So you look in an ear, it looks like this. What's going on? Well, there's a hole in the eardrum, what we call a tympanic membrane perforation. So what kind of thing causes this? Well, trauma. So two types of trauma, either a direct poke. So sometimes you see people with children the child pokes a cotton bud in their ear and causes that. And barotrauma. So pressure change, so suddenly jumping in a river and the pressure change bursting the eardrum. The most common cause is infection, so an infection behind the eardrum bursting through. And also some patients have grommets, and when the grommets fall out, the hole doesn't close. So this causes a couple of things. It causes hearing loss, and the waterproof barrier is lost. So that patient is more at risk of having infections, so discharge and hearing and discharge and hearing loss, and can also cause ringing in the ears, tinnitus. I can see someone's asking about that. I'll talk more about that in a bit. So tinnitus, ringing, can go with any ear problem. So it's not specific to one condition. So what do you do if you see something like this? Well, if it's a fresh perforation, you can ask the patient to keep their ear dry and not let any water get in the ear for 6 weeks. And sometimes they heal on their own. You need to treat any infection with ear drops. And if the hole hasn't healed by 6 weeks, then one option is to offer a Tympanoplasty, which is an operation to close the eardrum. Now, I do this operation under local anesthetic, but generally it's probably done under general anesthetic. But essentially it's an operation down the ear canal where you cut the ear canal skin and lift it up and lift up the whole eardrum, and then take some graft. So you can either take it from the tragus or the temporalis fascia. That's the two most common places. And you can see here, a piece of graft is being slid underneath, and then you lay everything back and then let it heal for 6 weeks. And that is a good way of closing the hole. Question, sudden hearing loss is an emergency, but what about ringing? So sudden ringing on its own isn't as much of an emergency as sudden hearing loss. But if a patient has got sudden pulsatile ringing, then depending on where you live and what the protocols are, it may be that needs to be urgently investigated to rule out a vascular problem such as a carotid artery dissection. If it's non-pulsatile ringing, then really the question should be, has the patient got hearing loss as well? And then if the patient does have hearing loss, then treat it as a sudden hearing loss. So I hope that's answered that question. Sometimes the eardrum doesn't develop a hole, but it becomes retracted. So this is a problem where the eustachian tube, which is the tube that links the nose to the middle ear, doesn't quite work as well. And so you get a negative pressure in the middle ear that you might experience when you fly. And that causes this shrink wrapping of the eardrum onto the promontory. So as you can see, you can start to see structures you wouldn't normally see, like the long process of the incus, the tendon to the stapes and the stapes head there. And this is the promontory of the cochlear. So all that you shouldn't usually see. And in its most severe forms, it can cause hearing loss and tinnitus. And what we don't want is for it to develop into this, which is a cholesteatoma. So when a retraction gets so bad, so in a normal healthy ear, skin will migrate from inside to out. And when a retraction develops, that migratory pattern can be interrupted. And instead of migrating from inside to out, skin starts to grow on itself. And that's what we call a cholesteatoma. Now, the problem is when this forms, it starts to behave like a locally destructive disease that starts to destroy the hearing mechanism. And in the late stages, it can affect the facial nerve and erode the base of the brain and cause meningitis. So we need to deal with this. And the only way of clearing it is with an operation. It can look like wax. So when you see wax stuck on the eardrum, think about cholesteatoma. When you see someone with a hearing loss and persistent discharge that isn't settling, think about cholesteatoma. Okay. So what is cholesteatoma? It's basically an abnormal collection of skin cells growing in the middle ear, so growing behind the eardrum. And as I said, these are the symptoms. And the only way to get that out is with an operation. Typically, you need to do an operation that is down the ear canal and also drill some of the bone behind the ear canal to get it all out safely without affecting the facial nerve. And there are various different ways of doing this depending on the extent and location of the disease. But broadly speaking, this is called tympanomastoid surgery because you're operating in the middle ear and also in the mastoid. Okay, good. So moving on, and I'll collect all the questions at a good point. So what's going on here? So this is obviously a sportsman. He's got a blood-filled ear. This is a Pinna haematoma, and it can be caused by trauma, but it can be spontaneous as well. And we know that if we don't treat this, it can turn into a cauliflower ear. So the cartilage of the ear that gives you its natural shape starts to necrose, and you get this rubbery texture. So For that reason, it needs to be incised and drained before that happens. So you can do it in the treatment room, local anesthetic, cut the ear, drain the blood, and then typically I will advise stitching a compressive dressing. These are dental rolls, but you can use other things, and stitch that in for 2 or 3 days, and then remove it. So that's a Pinna haematoma. Question: can cholesteatoma turn cancerous? No. So the two things are separate, but it does behave like a locally destructive tumor. It's not a tumor, but it behaves in that way, in the sense it just grows locally and destroys everything that's nearby. Okay, question. This is a 32-year-old patient, presents with acute onset of symptoms. What's going on here? Have a look and see what you think, and put the answers in the comments. I might also ask at this stage, is this helpful, and is this the level at which you're hoping for today? Just let me know, so I know whether to speed up or slow down. So I'll give you a bit more time. Great. So lots of different answers coming through. Okay. I'm going to give you the correct answer now. It's a left lower motor neuron facial palsy. So why is that? So when someone presents with a facial weakness, the first thing you want to do is to ask, as well as the lower down facial muscles not working. So this guy is trying to lift his forehead up and smile, but the left side is not working so well. So the problem is on the left side. What you'll also notice is that the forehead is involved. So the forehead is not moving. That tells you that it's a lower motor neuron palsy. So the facial muscles are not working on the left, so it's a left-sided facial palsy. And because the forehead is also not moving, it's a left-sided lower motor neuron facial palsy. When it's an upper motor neuron facial palsy, the forehead is spared because it has innervation from both sides of the brain. So that's how you tell the difference. And the reason it's not a Bell's is you can only call something a Bell's when you've ruled out all other causes of facial palsy. So if you think about the course of the facial nerve going from the brainstem through the middle ear, out of the stylomastoid foramen and through the parotid gland, unless you've looked in the ear and felt the parotid, you can't definitely say it's a Bell's because you haven't ruled out other causes of low motor neuron facial nerve palsy. So that's why the most accurate answer is left-sided low motor neuron facial palsy. Okay. So it gets complicated because there are different degrees of facial palsy. So students often get really confused about this. When you ask what happens in a facial palsy to the eye, and people will say ptosis. Well, actually, that's not the case. So the oculomotor nerve, the third nerve, opens the eye, and the facial nerve closes the eye. So if you've got a facial nerve that's not working, you will have failure of eye closure. So you'll have an eye that hangs open. However, why is it that some people have a facial palsy but can still close their eye? Well, that's because it varies in severity. So a mild weakness, they will still be able to close their eye, whereas in total paralysis, the eye will hang open. So we use this House-Brackman classification. There are other classifications, but this is probably the most commonly used one, from 1 to 6. Number 1 is normal. So most of us have a grade 1 facial nerve. Grade 6 is no movement at all. And the difference between 3 and 4 is that in 3, you can just about close the eye, and in 4, you can't. So it's useful for documenting so that when a different doctor sees that patient later down the line, they can see if there's an improvement or not. Okay, so that's broadly how to classify a facial nerve palsy. Okay, good. Okay, so if you understand the course of the facial nerve, i.e. the upper motor neuron from the cortex down to the brainstem, and then the lower motor neuron, its course through the middle ear, and then out of the stylomastoid foramen through the parotid gland to the facial muscles, you can start to deduce what the cause might be. So think about it like that. The most important thing about managing any facial palsy is that if the patient has a facial palsy, whatever the cause, think about eye care, because if they can't close their eye, you need to instruct them to use eye lubrication and tape the eye shut at night, because even if they can just about close it during the day, at night it will flop open and they're at risk of a corneal scar. So it's really important to, eye care is really important, okay? And then in terms of causes, obviously Bell's is when you've diagnosed every other cause, but there are loads of other causes. So trauma to the temporal bone, infection, cholesteatoma, viruses, cancers, autoimmune and congenital. So loads of different causes. Okay, good. And we've talked about that. So an MRI scan will usually be quite helpful to rule out problems that you can't necessarily detect on clinical examination. Okay, good. I've included some stuff about dizziness because ear surgeons look after dizziness, and everyone, it's a bit of a heart-sink topic because everyone really struggles to figure out how to handle this. So I've tried to simplify it for you. Have a look at this diagram. When someone presents to you feeling dizzy, what you want to do is think, at any one time, that patient's balance is dependent on loads of different things, but the main ones are visual input, so the eyes, that your vision telling you where you are in time and space. There are 3 balance canals in each inner ear, orientated in different directions. So when I move my head this way, the fluid in those canals shifts and tells my brain that my head has moved this way. Similarly, your joints and the feeling in your toes gives the brain feedback on where the body is in time and space, so that when I lean this way, my brain knows to put more weight on this foot and keep my balance. There's also the cerebellum, which is the kind of coordination center, and then all that is a positive, is a feedback loop, telling all those organs to make adjustments. So all it takes is one problem somewhere to cause dizziness. Now, in a young, fit and well patient, if one of these faculties has a problem, the others will slowly compensate. But in the acute phase, someone will feel dizzy. So I hope that kind of helps you understand a little bit about how to approach dizziness. So the history is really important. The first thing to do is differentiate the feeling of lightheadedness from true room spinning vertigo. In peripheral vestibular dizziness, i.e. dizziness that's caused by an inner ear problem, the symptom is rotatory vertigo. So if that patient has more lightheadedness on standing up, it's probably not going to be an inner ear problem, and you might want to involve cardiology. You also want to get an idea for the time course of symptoms. So how long does the dizziness last for? Does it go away on its own? Are there any accompanying symptoms? So does the hearing go at the same time? Is there ringing in the ears? And what happens when you close your eyes or when you stay still? So if you're dizzy at rest and without moving your eyes, then it's more likely to be a central problem. Whereas if the dizziness improves when you stay still, it's more likely to be a peripheral vestibular problem. So, and there are also some cardinal symptoms that might point to specific diagnoses. So that's probably a kind of a simple starter in dizziness in how to handle it. So, yeah, if they complain of light sensitivity and aura, think about vestibular migraine. In Ménière's disease, you get episodic vertigo lasting hours, associated with a drop in hearing and oral fullness and ringing tinnitus. So its pattern recognition is really important. And this is not a slide you need to learn, but just to illustrate that that's how you differentiate between the common causes. So the 3 most common conditions we see in the ear clinic are BPPV, that's benign paroxysmal positional vertigo, Ménière's disease, and acute labyrinthitis. So those are the sort of things you tend to see when the inner ear goes wrong. Okay, so BPPV, you might have heard of this. This is a problem where one of the semicircular canals, most often the posterior semicircular canal, develops debris in the fluid channel. And what happens is when that canal is full of debris, you get inertia of the fluid that usually flows smoothly. And what happens then is that you get motion provoked room spinning vertigo that lasts seconds. And that history points to BPPV. And the magic thing about it is that you can diagnose and fix it in the clinic with something called the Dix-Hallpike manoeuvre, which leads on to the Epley manoeuvre. And you can just go on YouTube and have a look. There's lots of videos showing it, but essentially it's a way of orientating the head in different ways and shifting the debris and getting people better. So check that out, the Epley manoeuvre. Meniere's disease I've already talked about. When someone's got a sensorineural hearing loss in one ear, they also need an MRI scan to rule out a benign tumor on the hearing and balance nerve. And you also want to be thinking about vestibular migraine and treating that. The two things do go together, as well as lots of other more rare conditions. So when you make a diagnosis of Meniere's, they've got low frequency sensorineural hearing loss, recurrent vertigo, tinnitus, and oral fullness, or a combination of some of those. Then we don't have a perfect treatment. So a large proportion of patients will be happy with a diagnosis and explaining it and just understanding the condition. It's important to treat migraine. And then there's some debate over how to treat it, and it varies between countries. So you might see beta histine being used. That's a drug that's used for Meniere's. And some people also advise salt, caffeine, and alcohol restriction. The evidence for these is pretty low. In America, in the US, bendrafluozide, so diuretic, is used a bit more than it is here. And probably the best evidence is for a steroid injection through the eardrum to bathe the inner ear in steroid. And that's probably got the highest evidence. If the hearing is gone, then there's less to lose in terms of a destructive surgical approach. So very rarely, some patients opt to have their inner ear drilled out so that they no longer have irritative signals to the brain. But of course, the hearing is sacrificed as a result of that. Okay, moving on, acute otitis media. So this is a condition that's very common in children. For children from very young upwards, complaining of a painful ear. If they can't talk yet, they might tug at their ear, have a temperature. And so you want to be thinking about this in those children. Now, the majority of this is viral, so it will get better without antibiotics. But there are some cases where giving antibiotics for a potential bacterial infection is important to prevent intracranial or local complications. In the UK, we have guidelines to give antibiotics to children under 2, children with both ears affected, any ear discharge, or any pain that's not improving after 3 days. Also, think about it in children with systemic features, immunodeficiency, or recurrent cases. So that's acute otitis media. Because if untreated, rarely it can result in this, which is called acute mastoiditis. Now, by the time the child attends looking like this, with a pushed out ear and a bulge behind the ear, they're probably going to need an operation to drain that pus. But they need to be admitted and given intravenous antibiotics. And before you do an operation to open up here and perhaps drill some of the bone, they're going to need a CT scan to make sure there is no intracranial complication, so brain abscess as well, because you're going to want to know that before you take the patient to theatre, just in case you need to involve neurosurgery. Okay. So acute otitis media with effusion, similar name, slightly different condition, although the two can go together. This is a problem where it's not so much painful, but fluid collects behind the eardrum and causes blunting of the hearing mechanism and deafness. It's very common in young children because the eustachian tube does not work as well as it does in adulthood. And so children can be noticed to be putting the TV up too loud or not responding to their parents. And it affects 5% of preschool children. Now, the thing is that most of these cases will resolve on their own. So we don't need to intervene for all of them. But we want to intervene for children who are affected by it for longer periods of time, because a child without good hearing is going to struggle educationally. So that's the reason to intervene, so that they don't have problems with speech and language development. In the UK, the guidelines in the Public Health Service are that the children should have bilateral glue ear for 3 months. but you could argue that that's probably quite strict criteria. If hearing aids aren't acceptable, then the fix for this is grommet surgery. You can see here the pictures where you make a cut in the eardrum. So you can do it under local in adults, but in kids, they need a general anesthetic. Make a cut in the eardrum, suck the glue out, and then put a small plastic tube which ventilates the middle ear. So it does what the eustachian tube hasn't been doing so well, in that it equalizes the pressure behind the eardrum and stops the glue from reaccumulating. Okay, good. So have a look at this question, and I will have a look at some of the questions you've been asking. So which of these is not typically associated with a temporal bone fracture? So there's a question about compensation. So yeah, so if one of the balance organs fails permanently, then the hope is that the other organs will compensate and learn to adapt. And so that's why you see many people with acute balance problems recover over time. In an older patient, those compensatory mechanisms are not as good, and that's why balance difficulties in older patients are traditionally a bit more difficult to solve. Oral fullness. Oral fullness basically just means a feeling of fullness in the ear. So it's a non-specific symptom. It can be associated with effusion in the middle ear, Ménière's, and some other conditions. Do I treat both adults and children? Yes, I do. I treat newborn babies who are born deaf and might want cochlear implants, up to very elderly patients. There's no age limit for me. Good. Okay. Right. So, which of these is not typically associated? The answer is trigeminal nerve palsy. So, a fracture through the temporal bone can disrupt the middle ear hearing mechanism. It disrupt the facial nerve. It can go through the inner ear, so causing a sensory neural, essentially a dead ear, and it can also breach the dura because the temporal bone is so close to the lateral temporal lobe. Trigeminal nerve isn't typically affected unless it's a really bad fracture. So temporal bone fractures, typically resulting from high energy injury. And so typically ENT may not see these patients when they get admitted. Obviously, resuscitating the patient, saving their life, dealing with other issues comes first. But if you can document the facial nerve function before that patient is, let's say, intubated and made unconscious, then that's really helpful, because getting an idea of whether the nerve was completely transected or whether it's a partial palsy that might recover is really important. Tuning forks, like I said earlier, can help determine between conductive and sensory neural hearing loss, which will help give a patient advice on the prognosis. A sensory neural hearing loss after a temporal bone fracture probably will not recover, whereas a conductive hearing loss may well do. And there's a way of classifying it. Essentially, the best way to think about it is otic capsule involving and otic capsule sparing. So an otic capsule involving fracture is more likely to cause sensory neural hearing loss and a facial palsy. So if you have a conductive hearing loss, it can be fixed later down the line with middle ear surgery. Like I said, sensory neural hearing loss is likely to be irreversible. Dizziness generally managed conservatively, but you want to be thinking about whether there is a CSF leak. Facial palsy, if it's transected immediately, there is a case for exploring surgically to try and repair it. Anything else, generally we'll observe for a period of time and give steroids. Okay, can ear problems be hereditary? Very much so. Yes, so I'll talk about that later on in the talk. Okay, top student question. We're getting towards the end actually. So again, this is kind of not something you may be expected to know, but have a go. Which of these hearing tests would you typically use in a child aged 3 years old? Have a look, and I will have a look at the questions. So I've got some questions about what I do and who I work with. You might, if any of you are on Instagram, you might be interested to have a look at my page. It's got lots of insights in life as an ear surgeon and the kind of work we do. Very much work with audiologists and work with newborn babies, but people of all age, patients of all ages. to try and help with hearing and ear problems. So as you can imagine, working with audiologists is a key part of being an ear surgeon. Okay, so we talked about pure tone audiometry earlier. So the answer to this is play audiometry, and I'll tell you why. So pure tone audiometry is where you put some headphones on the patient, play a sound, and ask them to press a button when they can hear the sound. Now, obviously, you're not going to be able to do that with very young children because they need to learn what they're being asked to do. So what do we do with younger children? So let's start right at the beginning. I was asked a question about, can children be born with deafness? And the answer is yes. So that's why we have something called hearing screening in the US, in the UK, and many other countries. And this is my son, who was born 18 months ago, having his screening test. This test is called an otoacoustic emission. So the probe is placed in the ear, a sound is played into the ear, and we know that a sound, an inner ear microphonic will play back. And when we know that that is in place, we know that there's a good chance that the hearing is normal. And so when children fail this test, they are then fed into further testing. So, excuse me. So newborn hearing screening, the first step. About 5% of children fail screening or are referred onwards, but only 1 in 10 are born with permanent deafness. This is visual reinforcement audiometry. So what happens is a sound is this is typically done from age 6 months to about 18 months to 2 years. So what happens is you play a sound, and then when the child turns towards that sound, then the toy appears and it's like a visual reward. So then the next time the child knows that when that sound is played, they know that if they turn their head, they're going to get given that reward. So that is a way of testing whether a child can hear a sound played at different volumes. So that's visual reinforcement audiometry. So useful from between 6 months and 2 years. And the answer to the question was play audiometry. So this is for children kind of 2.5 upwards, and essentially you can ask them to put a hoop on the pole when they hear a sound. So it's kind of a more playful version of pure tone audiometry. So yeah, so having different ways of testing different age children means that we can pick up problems early, and we know that the earlier we can offer help, the better the outcome, because picking up, so intervening early whilst children are developing their speech and language is really important. So if a child is born completely deaf, we know that we can offer cochlear implantation, meaning that they can learn. So in the first 5 years of life is when the brain learns to process speech and language. And so if we get in there early enough, then children can integrate into the hearing world with their peers that were born with normal hearing. Okay, and essentially, I mean, it's another lecture altogether talking about different hearing restoration surgeries, but this is a selection of what I do. And the take home is that nearly every patient now has an option to hear well in both ears. There are some exceptions, but generally there's always an option, and it's no longer a case of struggle on with a hearing aid or nothing anymore. And we know that restoring lost hearing has a positive impact on mental health, social isolation, particularly in the era of lockdowns and COVID, helping people to reconnect with their friends and family. And there's also an association with earlier cognitive decline with hearing loss. So patients with poor hearing are thought to develop dementia earlier than people with good hearing. And then there are more niche functions like knowing where a sound is coming from and appreciating music, etc. So there's more stuff on that on my Instagram, so feel free to check that out if you're interested. So a little bit about cochlear implantation. So in the UK, if we have a child that we detect to have bilateral severe to profound hearing loss, or an adult that had hearing and then lost it later, then that's the indication for cochlear implantation. So any patient that, however loud their hearing aid is turned up, they're still not getting enough function, that is the time to think about implant surgery. And it's a multidisciplinary a decision involving surgeons, audiologists, rehab therapists, radiologists, psychologists, and audiovestibular medicine. So it's a true team effort. And generally 7 months old is the earliest I will operate to do bilateral cochlear implantation on a baby. And patients over the age of 100 have also benefited from this, those patients that lost hearing later in life. So that's kind of the end of the talk. I thought it'd be worth just saying a little bit about ENT. Lots of people kind of don't get really exposed to it very much in med school, and so discover it late. Why did I choose ENT? Well, it's not all snot and wax as you might think. It is probably one of medicine's well-hidden careers in terms of its we look after a range of ages, from babies to children to young adults to older adults. And I do think that working with children as a specialty keeps you young, and certainly it sways the kind of people that go into it. Maybe as surgeons, we operate on more children than any other surgical specialty. It's a wide variety of cases. So ear, nose, and throat means that every day is different as a trainee. As you can imagine, we use lots of gadgets to look down orifices that other people can't look with regular examination equipment. And we get to make people better quickly. And we're impacting on the senses. So it's amazingly rewarding when you can restore hearing or restore smell to someone. It's people thank you for the rest of their life sometimes. The surgery is challenging. It's very delicate. And so, it does take years of training, and I had to bear that responsibility. But with challenge comes exhilarating reward as well. So, and I really enjoy the emotional impact. And generally, the kind of people in ENT, we're kind of known to be surgeons that are generally easy to get along with and enjoy life outside medicine. So those are my reasons anyway. That's my Instagram if you want to have a look. And I can see there's some questions coming in. The team asked me to make a quote. So here's some advice that I would have given my student self. Just never to lose sight of being kind to your colleagues and to other hospital staff. I always look at how the trainees treat the lowest grade of worker in a hospital compared to the highest grade. I think that says a lot about character, but also being compassionate to patients even when you're busy, going the extra mile for others, and maintaining a service-focused attitude. So these are all the things you want to be thinking about as a student. And those sorts of trainees tend to fall in the way of good advice and successful projects that enhance their CV. So yeah, don't be too focused on CV building above all those other things, which will come. Good. Okay, so that's me. I've written a couple of books for trainees. They are kind of geared towards the UK junior doctors exams, but equally they are helpful and available on Amazon in other countries. So have a look at that, and I will try and answer some of your questions. How do you feel about the deaf community stigmatizing cochlear implants and excluding them? So that's a really interesting question. So just to kind of reiterate for those that are not sure, that obviously not all deafness is genetic and not all deafness runs in families, but there are certain genes that cause profound deafness, and so therefore there are some families for which deafness runs in the family, and those people in that culture may not see deafness as a bad thing, and sign language and other forms of communication are very legitimate languages, and so there will be some people that embrace deafness and choose that life. And as an ENT surgeon, it's my role to understand those sensitivities and work with them. And it's not a case of it's not a case of kind of offer or discard you. Part of the assessment is understanding those sensitivities. So I would hope that the deaf community kind of appreciate that cochlear implants are an option, and they're a choice that an individual or individual parents can make, and integrating a deaf person in the hearing world doesn't mean that they can't learn sign language and integrate with their deaf family as well. So it's about kind of getting those two things to work together. What's my schedule like in ENT? So my working week is a combination of outpatient clinic, operating theatre, multidisciplinary team meetings, and emergency on-call. So where I cover the ENT emergency rota. So that's my schedule at ENT. How does post-operation aftercare work with cochlear implantation? Yes, so the surgery is just literally to put the implant in the ear, but that's only a part of the story. The brain then needs to learn how to interpret new electrical signals as sound and speech. So that's where rehab comes in. So the implant is switched on around 4 to 5 weeks after the surgery, and then it's intensive rehab, training, giving the patient exercises to train the brain to understand the new signal. So generally that improvement in audition tends to carry on for up to a year. Do I use sign language often? No, but I would love to. I just haven't learnt. So when I'm communicating with sign language users in the clinic, I'll generally work with a sign language interpreter to make sure I'm not getting anything wrong. But if any of you have the option of learning sign language, it is a great skill to have, without a doubt. Good. Any other questions? Otherwise I'll have a look. Who's your football club? By football, I presume you mean soccer for the American students, but I follow Aston Villa, who are a team in the Midlands in the Premier League. And that's because I grew up between the age of 4 and 13 in Birmingham. And I've suffered ever since because they've had a difficult time. But that's what builds endurance. So there we go. Do you use robotic surgery in your surgeries? So I don't at the moment. Robots are used in ENT for transoral surgery, for throat surgery, and also for thyroid surgery. They've been trialed for cochlear implants, but it's not yet the norm. So I don't personally use the robot, but I do use endoscopes and other technologies. How frequently do you work with OT, PT, and speech and language therapists? Well, my wife is a speech and language therapist, so maybe that answers your question. But I work very often with, certainly with speech therapists and audiologists. I work with physiotherapists sometimes for patients who have got musculoskeletal problems in this area, but speech therapy and audiology very much so for the rehabilitation and assessment of people with hearing problems. What exercises are done in rehabilitation after a cochlear implant? Well, that is probably a whole other lecture. So, but essentially, it consists of making adjustments to the electrical signals, and then getting that patient to say what they're hearing, and then train. So that's broadly what's done. I probably need an audiologist to really give a proper answer to that question. How many years was your residency? Okay, so in the UK, medical school is an undergraduate degree, or it can be an undergraduate degree. So you go in at 18 years old and spend 5 or 6 years. And then you do, once you graduate as a doctor, you do 2 years of what's called foundation training, and then 2 years of core surgical training, so basic surgical training, and then another 6 years of specialist ENT training. So that's 10 years in total. I then was lined up for this quite specialist job. So I did an extra year, what's called an advanced fellowship at Cambridge University Hospitals in hearing implant surgery and otology. So I did 11 years in total of training. So do you see patients with long-term hearing loss over long periods, or do you usually see patients a couple of times? So both. So sometimes I can just fix the problem and send people on their way. Some people have chronic conditions that need monitoring, particularly cholesteatoma needs follow-up for a few years because it can recur. So yeah, it really varies. where do you see ENT going in the future? How do you think it will change in 5 years? So I think the challenge for us all over the world is to figure out how we reduce footfall and how can we embrace telemedicine, which, as you can imagine, has been embraced a lot in COVID times, but it's a real problem for ENT because how do you look in an ear over the video? And so what we're seeing is devices being developed to clean ears and video ears and send that remotely. And so I'm trying to set up televideo otology clinics that can harness that technology. So I think that's one way ENT will go. And I think probably we'll need to see the expanding use of allied health professionals as first line. So audiologists as the first line to assess hearing difficulties, speech and language pathologists to assess swallowing difficulties. Yeah. What are examples of throat diseases you deal with? So I'm very specialist in ears now, but as a trainee, I would do things like tonsillectomy, vocal cord surgery, head and neck cancer. So yeah, voice problems, head and neck cancer, thyroid problems. So loads of different throat diseases. Do you find younger people dealing with hearing loss more frequently because of listening to loud music in headphones? So I was interviewed about this recently, and anecdotally, I don't know whether we see the younger people. I think you probably see the results of noise-induced hearing loss when people are older. But we do see people of all ages with hearing-related issues. And those of you that have iPhones will probably see with the latest iOS update that there's now a warning on headphone volume. So it's something that we're becoming more aware of, and hearing is precious. So yeah, and listening to loud music can cause noise-induced hearing loss. What advice do you have for people to take care of their own hearing? So firstly, don't stick anything in your ears. So nothing smaller than your elbow inside your ear. That's the first thing. It can only go badly. And if you notice a change in your hearing, get checked out early. So don't miss the boat, because if you have a sudden sensory neural hearing loss, there is a time window in which steroid treatment is helpful. So and then use hearing protection when you're in noisy environments. Yeah, those are my 3 top tips. Any other questions? I'll just have a look at the Mark Sloan from Grey's Anatomy. Grey's Anatomy, what a great show. That definitely inspired me into surgery. So shall I carry on looking at the questions?
I believe there was only one more question.
And it's, do you work with musicians often?
Okay, so I do have a steady stream of musicians coming to see me because I have an interest in hearing, and also because I am a musician in my spare time. So I play in a function band. So I guess that kind of gives me an extra perspective, and people appreciate that. So I kind of understand what it means for singers to have even slight hearing loss. So yeah, so not so much in the public sector, but yeah. What other ways do you recommend removing wax other than Q-tips? So generally, most people don't need to clean their ears, and a bit of wax is okay. It keeps the ear canal sterile, and that's fine. But if wax starts to build up, and some people are prone to it, there's a small number of people will be prone to wax buildup causing hearing loss and pain, then they should have it professionally microsuctioned. So microsuction by a professional is the best way of having it cleared. So, but all these other techniques about ear screws and candling and things, it's all to be avoided. Definitely.
Thank you so much, Dr. Manjaly, for presenting for our web shadowers. We loved how interactive your presentation was, and thank you for answering all of our questions.
Pleasure. Thanks for having me on, and yeah, happy for any other questions. If you DM me, I'll do my best to answer them.
Everyone make sure you check out his socials. His Instagram is Ear Surgeon Joe.
The link to the Google form has now been posted in the YouTube live chat, and it will also be in the description of this video as soon as it's over. So please fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Manjaly. It was an honor to have you again. We learned so much from you.
Great, thanks for having me, and good luck to everyone. I hope some of you are encouraged to choose ENT.